As usual, another great guest, but a quick diversion. You'll notice that our full name is the Marketplace for Health, Wealth, and Freedom. Well, let's talk about your health for a moment. If you'd like to escape from the stranglehold of insurance and be able to see alternative doctors or go across state lines for care, then you definitely need to take a look at patientempowerment.mpb.health and see if that's the fix you've been looking for. Now, let's get back to the show.
Welcome everyone to Freedom Hub's weekly health webinar. We title it differently. It used to be Cash Patients, Cash Doctors, Free Market or something. But it's really about the innovation in healthcare that so many of us are involved in. And for 4 years now, every week we featured leaders in innovations in healthcare. We've had a lot of DPC presentations over those years. And a couple of the doctors are with us today. And Gayle Brekke, if I'm pronouncing that correctly, I'm sure she'll correct me if I'm wrong. And I connected on LinkedIn over the past few years. So many of us are all LinkedIn enthusiasts, trying to save the world with our wonderful posts. And in fact, Dr. Gold, who's on this program, very nicely, very good timing, posted a Benefits Pro article that made me change the title of my reminder email today, because this just was astounding. I thought COVID scared away all the patients from the doctors over the past 2 years, and on the flip side, elevated telemedicine, and now the patients are going back to their doctors. Apparently, that did happen, except for one segment of the provider world, and that's those primary doctors who accept monthly subscription payments from families and workers who want to have unlimited access to the doctors. DPC expanded over 20% in 2020. And we'll get to that, I'm sure, in Q&A, if not with Gayle. And you have to ask yourself, why is DPC becoming so popular? Why are advisors like George Klassen, who's on this call, really pushing CEOs, CFOs, HR to use DPC as your entry point to control cost and to make patients happy? And that's an important criterion, I think, patient happiness. And another stat about, and Dr. Gold and others will correct me on this figure, what percentage of sicknesses and accidents can a primary care doctor resolve without having to refer to a specialist? I've heard all kinds of percentages in the high amounts, 70, 80. So it's, I guess you could almost argue it's a panacea. We'll see. Gayle is a long-time actuary and underwriter. And asking her before the show, why is she so focused on DPC? She said it's because of her background as an actuary. She realized to fix this broken cartel, an actuary has the training and knowledge to see the primary entry point around that monthly payment model as a key to controlling healthcare costs. She is a member of the Concerned Actuaries of the United States, of the US. And again, she's had lots of actuary and underwriter positions in insurance companies and elsewhere, mostly it seems around Kansas. She's in grad school, getting her doctorate at the University of Kansas. And Gayle, I'll shift it over to you to tell us your story and why we need to really get behind DPC as a key point to better healthcare.
Great. Thank you so much, Charles. I really appreciate the invitation to be here and the nice introduction. So I thought what you all might be interested in is just to hear a little bit about my perspective and how I came to be so interested in direct primary care. I think there are a lot of people now talking about DPC, which is all great. There are so many great clinicians talking about all the ins and outs of running your business and how to think about taking care of patients and all of that. And so perhaps my story would be a little bit different perspective, and maybe, light off some fireworks in your brain, or some insights for you, or some maybe different ways to think about the impact. And, for what it's worth, I, in a lot of ways, consider myself kind of an outsider to, what you all family doctors and DPC doctors and clinicians do. I am, just a regular person. I happen to have some background, kind of in the math and statistics, and, and all the management of insurance and selling to employer groups, and all that kind of fun stuff. I have no medical training, no background at all as a clinician, but I think I'm just, really curious about how things work, curious about why everything we try to do to fix the problems in the healthcare system doesn't work, and usually makes things worse. And that's really, kind of the basis for how I got to the point of really being interested in studying direct primary care from so many different angles. I came to first hear about DPC, I want to say about 12 to 15 years ago. And so I was still working as an actuary. I was fully credentialed, so I was done taking exams. I had a little bit more time that I could, look at other issues, or just become interested a little bit more broadly than trying to pass exams and, do my work and, take care of my family. And so I first came across DPC, and I started looking at it and reading articles. Dr. Josh Umber was one of the first people I came across. And at first, my thought was, this sounds so great. I mean, this sounds, really wonderful, and really, I mean, the doctors that are doing this are so happy. But there must be something I'm not seeing, some, maybe a little hidden dark corner of, that they're not talking about, but that's kind of maybe a little bit of a dark side. And so I just started talking to more people and doing more research and doing more thinking. And I still am looking for the dark side, and I haven't found it. I just, and then I became even more fascinated. It's like, wow, this great model is out here. People are doing this. It makes so much sense from an actuarial standpoint, because you're handling the routine parts of healthcare the way we handle the routine parts of taking care of our cars and our houses and, everything else. You pay for the routine things yourself because they're important for everybody to do. It's important to stay on top of the maintenance of your car if you want to avoid, needing a new engine next year because you're not doing oil changes, or, whatever it might be. But it just makes so much sense from an actuarial standpoint, and it's aligned with how we do things in the rest of our lives, how we think about taking care of things, how we think about buying other goods and services. So I think that just made me more interested in it. And then when the Affordable Care Act passed, I was just truthfully dumbfounded that I hadn't been watching the legislative process really closely. And I was just I kept, looking at the news occasionally, waiting to hear something about the country's going to have this dialogue about this big, huge healthcare reform that is going to change, so much about the way we do healthcare. And I just kept waiting for the dialogue, for the debate, for the discussion. And it never happened. They just passed it. And so I remember sitting there when they were showing the House passing it for the last time, and then the president was going to sign it. And I'm saying to myself, what is going on? It doesn't seem like they talk to anybody like an economist or an actuary that knows about insurance, that knows about human behavior when it comes to choices under uncertainty, if I want to sound like an actuary for a second. But I was just like, how did we get here? How did this happen that they passed this huge law that was going to, affect everything? And it doesn't seem like we had any kind of real discussion about why they thought this was a good idea, why other people thought it was not a good idea. So that's when I started thinking about how I could become more involved in the healthcare system and, not, to use air quotes, not just be an actuary doing my actuary job, but to try and learn more and to understand more, and maybe in some way get a little bit more involved in how we do healthcare in this country, because it seems like we're not doing a good job as far as trying to make it better and trying to really understand what's happening. So that's when I started to think about going back to school again, and I found a program here locally that I really liked. I started the doctoral program, finishing up my dissertation now, which is on direct primary care. And so it's been an interesting journey, because I think at first, when I went into the PhD program and I started, doing little research projects and thinking about what I wanted to do for my dissertation, I was focusing on the direct primary care piece. And so I did, I was looking at how you can do quantitative. Of course, my background as an actuary is a lot of it is about the numbers and the data and the claims data and all of that, which is great and really interesting. So there's the quantitative research, and then I had some coursework in qualitative research as well. So doing interviews and focus groups and talking to people. So I became more exposed to a lot of different kinds of research methods, not just the sorts of things actuaries focus on and the kinds of data actuaries focus on, but surveys and just all different kinds of research approaches. And so I focused on it that way for a while. And then I started to become more interested in some of the broader questions, looking at direct primary care versus how primary care works in the traditional system, if you will, or when we're using insurance or third-party payment for primary care. What are the experiences in primary care in that setting, where you have, the patient experience, you have the physician experience, all the ins and outs of what happens with downstream care when somebody needs a referral, or all the issues. And there are so many issues, of course, as you all know. There are a lot of challenges in primary care, and it seems to me, from what I read and what I observe, that we've also been trying a lot of reforms focused on primary care. And these are, broad ranging, different kinds of topics, like access. What kind of access are people experiencing? Can patients get in to see a primary care doctor when they need something? Do they have a long wait? Is the visit really short? Like, what happens in the visit? All of those sorts of things. What's the doctor's experience? How much time are they spending? So the income versus specialist is another big piece, and all of the issues around workforce and the concern about the shortage of primary care physicians. The administrative burden, how much time family doctors in particular spend doing charting or doing, different kinds of reporting and different kinds of, data capture that they have to do a certain way so that they can get paid. And so just looking at it, maybe from just being curious and also from a researcher standpoint, I just became really interested in the contrast between direct primary care, the experience of it for the doctor and the patient, versus third-party paid primary care, if you will, and the patient and provider's experience of that. And then, of course, you can do a whole series of other research questions and investigations beyond that, in terms of what happens downstream, what happens to the patient's health. It's just, the questions that you could investigate are really endless. But I kept coming back to all the things we're doing don't seem to work. The primary care community, if you will, leaders of primary care organizations, and mostly I focus on family medicine, although internal medicine certainly is a huge part of it as well. Although, I think there's more focus on being a hospitalist and, some of those sorts of things. So it's not as much of the same office-based, relationship-based primary care mechanism or structure as it is with family doctors. But just this huge contrast between DPC and traditional primary care, and then just kind of this whole way that we think about what primary care is. And right now, what I'm really interested in is this notion of, if you start with direct primary care and you kind of build, I don't even want to go so far as to say build a healthcare system, although I'm sure there are people that, kind of go there. But I'm just looking at it from the standpoint of, thinking about this primary care experience and how that kind of sets the stage for everything that happens after that to the patient in terms of downstream care, in terms of how they think about care, how they think about getting a surgery if they need surgery, and it depends on if they have insurance, beyond primary care, if they have a health cost sharing community that they're a member of, if they have some kind of an account where they're able to have money put aside to pay for things, or maybe they have coverage through work. So really their behavior, I think, downstream with downstream care will depend a lot on, kind of the whole picture, the DPC plus if they have some kind of financial protection for more expensive healthcare. But just this mindset that we seem to have in this country that healthcare reform and just the healthcare system, what I call the status quo mindset, or the conventional thinking, seems to be, we have to use insurance for everything. We have to have more and more services covered by insurance, whether it's, I'm sure the doctors on the call could, throw out all kinds of great examples, but, there's all kinds of, counseling and, hearing aids and just all kinds of more minor or routine or aspects of what would traditionally be considered primary care. There are people that are lobbying to have those be required, elements of coverage, which on the one hand, I think they're looking at it as, we want people that need this to be able to get it. But this, the downstream or the long-term impact of that kind of thinking and that kind of an approach is that insurance becomes so expensive, which is, I think, where we are now, that for many people, it's not a viable option anymore. So I think we have to go back and rethink how we think about healthcare. And in my view, primary care should not be seen as the way to get people into the system so that they'll use more downstream care or use your particular hospital or use your particular service. I think we should go back and rethink primary care is more like the oil changes and the tune-ups. And it's so critical, if you'll give me a little bit of leeway with a metaphor, that's not perfect, but I think it's so important to have somebody that you trust to take your car to, and that is very knowledgeable about how it works, to say, to help you understand how to maintain it or what the issues are coming up. And that might correlate to somebody with a chronic condition. It's so important to have that trusting relationship with your provider, where you can get the help you need early on, kind of from a maintenance standpoint. So you prevent all of that downstream care. And I think that's another area that I wanted to mention that is really interesting is chronic care and complex patients and patients with multimorbidity, they are very, very poorly served in the traditional healthcare system today. But I think, the more we can look at that and study that and think about that in terms of direct primary care, that maybe even more than anywhere else is where direct primary care really shines, is with the complex patients who need somebody that understands not only their medical challenges, but their treatment preferences, their goals. Are they wanting to run a marathon, or are they wanting to just play with their grandchildren in the yard and not get so tired that they can't do it? And that's all very personal and intimate, and it's not just a commodity. It's something, I think, very special, and we need to, look at primary care with fresh eyes and rethink how we should be doing it, and not just look at healthcare reform as we need to tweak Medicare and Medicaid and get, squeeze a little bit more out of this, budget that we have. I think if we're going to try to actually improve our healthcare system, we have to rethink from the beginning. And I mean, my interest in direct primary care, I think, has led me down this whole path. And in some ways, I feel like I'm just getting started. I'm hoping to continue to, kick around these ideas and work with people like the concerned actuaries, or like groups of DPC doctors, or whatever it might be, to try to really have the conversation in this country that we need to have about healthcare if we really do want to make things better. So I know that was longer than you wanted me to go, Charles.
No, that's perfect. We're pretty flexible. Every pitch, has its natural length. And so that's what you needed to say your piece. So that was perfect. Let me share my screen for our sponsor, which by coincidence was featured in Forbes as one of the best Obamacare alternatives. It is sharing, which is half the cost of insurance, and it doesn't have networks. And I always tell folks who want health insurance, why would you want insurance? They use networks. So if you get cancer or a heart attack, they infamously exclude the centers of excellence in almost every state. There's no networks in sharing. And here's our piece with DPC. It's called Direct. And if you scroll down, you'll see we give you a lot of free telemedicine and counseling, and a concierge to help you find all the specialists that you'll get coached on with your DPC as well. And if you're before age 50, age 49, if you get our cheapest one with a high out of pocket, $5,000, that's less than $200 a month. Pretty good price. And you've got the DPC, as I'm sure Dr. Gold can attest if he wants to raise his hand, can resolve up to 80% of all your sicknesses and accidents. So now you really just have a cheap catastrophic piece that uses sharing instead of insurance. And you've got your DPC to handle all of your regular costs. And if you have any other out-of-pocket costs, we have, let's see here, let me just hide this real quick. The HMA, and George can support this as well. This doubles your money over 3 years. And, there's a stupid government rule that prohibits you from having an HSA with a DPC, although that's kind of a vague rule. The HMA is really your best out-of-pocket solution, doubles your money, and covers pretty much all your out-of-pocket that you don't get covered in your DPC. $84 a month doubles to $5,000. That allows for that $5,000 out-of-pocket sharing. You've got your DPC for what, Dr. Gold, $75 a month on average. So I'll stop sharing. You add it up. That's $300 a month total protection, $300 to $350. Let me just go back to here and return the meeting and stop sharing. That ends that ends my promotion for the best solution in the country for DPC, for catastrophic and out of pocket. Dr. Gold, do you want to comment on Gayle's presentation? Because you're our DPC here in the audience, and you do it every day, and you post about it on LinkedIn. In fact, as you probably heard, it was your post yesterday that changed my title of today's event, because I don't think anyone knew that DPC did not suffer during COVID.
Yeah, I mean, Gayle just stole it all from me anyway. I mean, basically, I just felt like I was listening, to myself talk. A couple things I do want to add. As I said in the chat, I have this really great meme that my colleague Vance Lassie did around the time of COVID that involves DPC and COVID, and I'm trying to share it in the chat, but I have no idea how to do that. So, Charles, I'll send it to you on email, and you can. It's totally appropriate. It's just a very funny meme, because I think that, as you said, not only did DPC survive, but it actually grew. I think that, we didn't change anything about how we operated during COVID, other than maybe pushing, routine well child checks and routine checkups, down the road a little bit. But we were still seeing patients. We were, if we needed to, telehealth was already included. So, there was no major change there. And, I think the reason this model is so complicated to employers and the general public is because it is simple. That's the irony of it, is I think when you have taken this convoluted labyrinth that we've all been in the middle of, an experience, whether it's with us or family members or close friends, when something comes to you that's simple, it's very, very challenging to actually think simply and logically, because the system we have is so illogical and complex. The one thing I do want to add is, and I think this is the biggest challenge, I have in the greater Boston area, which is obviously very highly specialized, and big hospital systems rule the roost. And a lot of the patients up here think that, for every problem they have, they need a specialist for that problem. So I think, even taking a step back from direct primary care, I think we need to kind of figure out how to educate employers and the public on what real primary care even looks like. Because I always try to see things through the consumer lens as well. And when you look at what patients have been experiencing over the past few decades of primary care, they really do think all you are is a referralist. You're there to come in for your 8-minute or your free checkup, get told where to go here, have a bunch of free tests done, and move on. And what we're trying to do is get back to where primary care can actually function at the extent of its training. So I agree with you that I think 80% of chronic disease, acute urgent care can be managed in the primary care setting, but it can't be done in the current primary care setting that most people know and experience. And that's where, it's like you almost have to kind of uneducate the public on what primary care looks like in their eyes is not real primary care. It's the bastardized version of how to help the system make money. It's not primary care. And that's why, nothing against mid-levels, but that's why you can fill these urgent cares and hospital-owned practices with nurse practitioners and PAs, and it just does what it's supposed to do. It just feeds the hospital system and it feeds the insurer's pockets. We really have a big challenge. And I wish I had the magic bullet to figure out how to change the psychology of the American public. But two tenets that they've been brainwashed to believe are that having insurance guarantees you good quality, affordable care and access, and that without insurance, you can't access any of those things. And both of them we know are BS, but we know that. How do we get that message to the public? It's how do you get them to accept the fact that they've been literally duped for decades and robbed from? It's a tough thing to admit. And there's so much psychology behind this change. And I literally agree with Gayle. I think it's just a very grassroots effort to rebuild from the bottom up and scrap, the garbage that we have, which people just don't even realize is garbage. But, we help people navigate the system for quality, cost. We offer as much as we can to keep them within this space where things are, accessible, affordable, continuous, longitudinal, and keep them out of that fragmented space, but they have to want that.
So Gayle, so Jeff, you're saying an expanded idea of what primary care is, number one. Number two, you raised the problem with the corporatization of hospitals where they're replacing MDs with sub-MD levels, and that could lead to some malpractice. And then number three,
I'm not against mid-levels at all. Like, I think, we hired a female nurse practitioner that was a student of mine. I actually did as a favor. I usually don't teach NP students. And, she was such a great fit, but we literally share an office together. She's supervised, runs everything by me. It's almost like the patients that are signing up with her are getting a 2-for-1, really. But when you start having these facilities where there's no on-site supervision, the level of quality between, a really good, NP versus there's a big steep difference. And, there's a difference between collaborating and assisting versus taking over a practice. And that's where I have issues.
Yeah, that's a growing issue. And then the third thing was the idea that coverage equals insurance. And Gayle mentioned other combos with DPC, like sharing. 3 things to respond to real quick, Gayle, before we move on.
Yeah, I would love to take what Jeff was saying about grassroots and bottom up as, ways to think about DPC, and to just talk a little bit about an example that to me is very illustrative of the huge contrast between bottom up and top down. So top down is the way we're so used to thinking about healthcare. Reforms, whether it's the ACA or any other reform, is all about treating everybody the same. Everybody has to follow these rules that some, bureaucrat or, whether they're an actuary or whatever they are, if they're trying to manage the whole system from the top down, that's not going to work well. But that's how we think about healthcare. And DPC is completely the reverse of that. It's about the doctor-patient relationship, the direct relationship in primary care. And that, in a lot of ways is the beginning or the foundation of primary care and health and all of healthcare. So it's this huge contrast between a top-down way of looking at the world and a bottom-up way of looking at the world. And the best example that I can think of the impact of this contrast is this issue of telehealth. So when the pandemic started and they were making changes to CMS or a waiver or whatever the right terminology is, so that doctors could get paid to do telehealth visits with their Medicare beneficiary patients, so that they had some care and could get their concerns, brought forward and so forth. It ushered in this enormous discussion among policymakers and researchers and, all of these, huge efforts of, hundreds of researchers and, just different ideas about how can we do this and how can we manage this and when should the waiver end and, how should all of the rules about what counts as a telehealth visit and how much are they going to get paid and just, I'm on, different sorts of email lists and things because of my, kind of my foot in academia. So I see all of these huge projects that were kicked off. And like I say, hundreds and thousands of researchers and, millions of dollars went into these questions about telehealth. And I'm sitting over here thinking, but DPC does it naturally because it's bottom up. They're motivated to do what makes sense for both the patient and the doctor. And every DPC that I know of just automatically does this because it makes sense. And you don't need rules. You don't need this huge monstrosity of bureaucracy to say how it should work. The doctor decides, maybe reviews some different platforms, decides what kind of, a platform makes sense for their patients. Do they want it to, make sure that they always have a video capability and, whatever it is, but it's just something you automatically include because it makes sense and you're not, you're freer to do what makes sense in your business as a DPC doctor. And just the contrast between telehealth top down and telehealth bottom up, I don't think there can be a starker contrast. So just food for thought about the top down versus the bottom up and how we have to change how we think about healthcare in this country.
Jim, do you mind if Murray goes first? Real quick, go ahead, Murray.
Oh, thanks, Charlie. Gayle, good to see you after meeting you with Hunter a couple months ago.
You as well.
Anyway, as you know, I've just finished my latest book on medical insurance, which has a section there on DPC as my first book on universal medical care, and I'm not looking too good, Charlie. I have to run it, so I won't put on the video, if that's okay.
Yeah.
There are several things to unpack here. I think how we relate DPC to the average person and the employer is that we already have monthly payments for services. It's called cable TV and cell phone service. So we just have to relate medical care to that same approach, which everyone is used to. They're used to paying a monthly bill for internet service, cable service, and what's the other one? I just
Utilities of all kinds.
Yeah, so we
Take care of
pay
your house.
monthly. Rent is another example. We pay our mortgage. Having said that, the real challenge, to piggyback on what Jeffrey said, the real challenge in America today is that, as you know, medical practices are being taken over by hospitals. And so instead of going to the decentralized model, we're going more to the centralized model in primary care. So that's the real challenge we have. So what's one of the solutions? And here is where I think medical schools should be working with people who are promoting DPC, like Charlie and others, is really go into the medical schools and teach medical students about the benefits of DPC and bring in DPC doctors to show students that they would be much better off in a DPC practice than in a big medical practice that they're now probably going to go into. Having said that, what incentives can we use besides the benefits that you all know about from DPC? And here is where it gets kind of interesting. I would suggest that if we're going to lobby for anything in Washington, it would be for tax credits for medical students who graduate and become DPC doctors. We use tax credits for all sorts of incentives in our economy. So let's use it for something that is really beneficial, that would challenge the cartel, that would promote DPC. And I think it would benefit individuals enormously once they realize that they would be much better off with DPC and get back medicine to what the old doctors were when I was growing up back in the 1950s and 60s in New York City, where the doctor would take care of you. And if you needed a specialist, it would be few and far between, because as a youngster, you really don't need a specialist. And as you get older, you need a specialist. So I have to see a specialist this afternoon for a checkup. But the point is, there are ways that we can skin the cat, so to speak. And again, I'd be happy to work with Gayle. I'd have work with Charlie, because once I learned about DPC, I said, this is a no-brainer. This is essentially what it was like almost in New York City, except you didn't pay a monthly fee. And so, but back then the office visit was $5. So I think we could, with today's inflation, if you pay $200 or $300 for a couple per month, I think that's a real bargain. I really do, especially if the doctor's going to take care of most of your medical needs. So that's my 2 cents,
Oh,
Gayle.
yes, absolutely, Murray. The whole membership structure, the membership fee, the monthly membership fee, I think is great in so many ways. I mean, I use DPC myself, and I love having a doctor, essentially a phone call away. And she does, I mean, her calendar does fill up, but she's got 2 NPs that work for her who are also both fabulous. And they all talk, with each other every day about the patients they're seeing. So even if I have something more urgent that I can't wait, a week or something to see my physician, my DPC physician, and I need, a strep test or, something a little bit more routine, I am completely comfortable going to any of them. So it feels great to me to have a very affordable monthly fee. And I basically have this whole team on retainer. That, and they're very responsive, they're very, personable, and it's just wonderful. And I mean, this is kind of neither here nor there, but I also have really found it interesting to observe what DPC practices feel like. Just when you walk in, the decor is so inviting, and so, it just feels, does not feel clinical at all. It feels very inviting. It feels, the ones that in particular, maybe that are run by women are very, soft colors and, very up to date, nice, decor that feels very inviting. And, they take so much pride in what they're doing. And they have the freedom to, kind of express themselves. And it doesn't feel like a doctor's office. It feels like, I don't know what, like the spa or something, because it's just this wonderful feeling of, I'm going to be cared for here, attention to detail. And again, it's a minor point, but, to me, the contrast between the traditional system and the freedom system or the bottom-up system or the DPC system, is just so interesting.
Just a quick follow-up, Charlie, then I have to leave. The other way to sell this is that a lot of people have gym memberships. You pay that on a monthly basis. So instead of having a membership for a gym, you have a membership to a doctor to improve your health care. So I think that's a good analogy to use, because I think that really puts a holistic approach to the whole thing, gym and the doctor if you need it. Thanks, everyone. Thanks, Gayle. Charlie, I'll speak to you soon. Okay?
Jim, do you mind if Dr. Gurnita goes first? She's got an appointment at 10. Go ahead, Dr. Gurnita. Diana.
Hi, everyone, and thank you for the invitation. I hope you hear me well.
Yep.
Because I'm in an office without too much signal. So I am a specialist. I'm a rheumatologist, and I started in direct care about 2 years ago. And, if you have trouble to make people understand why you exist in DPC, guess what? We have even more problems with our patients because they don't understand very well why they pay insurance and why they have to pay a doctor on top of that. And I can tell you that from my experience, there are so many specialists that will jump on the boat, or jump out of the traditional system to the direct care. However, there is this huge fear that we cannot exist without a referral system in the behind. So you are our hope. The DPC practices are our hope to refer patients to us or to open the door for peer-to-peer consultations, which I'm offering to direct primary care physicians, because I think there is need for us. And I know that you handled the situation beautifully for the last 10 years or 15 years since you start. But as a specialist, I'm very, very happy to be of help. And I know that there are many other specialists like me that they will do the same for you. Thank you for the invite.
And we'll have Dr. Grace Hodges next Wednesday at noon, a podiatrist on direct specialty. We've had a few of them. That's the next level. Real quick, Gayle, Dr. Gold, you want to comment on the direct entrance of the specialists that you know?
I would like to comment on Dr. Gunita's statement there. I think it's great. I think it's wonderful that you're, looking to DPC as your hope, and you're, very happy to take direct patients or consultations or what have you. My comment, I think, is maybe a little bit more about the experience of the patient and the importance of bottom up. So last year I needed something beyond DPC, and I think we do tend to think, oh, the system is so rigged against patients, and the networks are kind of what everybody wants to focus on, and it's really hard to get care if you're trying to work through DPC. And certainly there are challenges and barriers, but I think from an individual patient's point of view, if you have a need to go to a specialist or go to a hospital, my belief is they are going to do their best to take care of you as a patient. So if you're direct paying, they're going to take your money and they're going to take care of you. So really I feel like, again, I know I keep talking about the bottom up versus the top down, but if we think about the bottom up and the patient experience of going to a hospital for a procedure, going to a specialist that you're referred by your DPC physician, my experience was wonderful. And I was actually quite surprised how easy it was, how quick the hospital was to give me a cash price for the procedure that I needed. And, I actually kind of got a kick out of it. And I've, kind of had my researcher hat on and my patient hat, but I was surprised and very pleased that they had a cash price right at hand for my procedure, that they were happy to share with me. They wanted me to know how much less it was than the regular price. So to me, that was great because they were treating me like a customer. I was coming in with money. I wanted to buy something that was valuable to me, that they could provide to me, and they were ready with a price, and the price was a good, fair price. I compared it to what you can find on the Surgery Center of Oklahoma's website. And I was super impressed and pleased that this large academic medical center was right there, ready to take care of me as a cash paying customer. So I think if we think about it from the bottom up and at least give it a try, at least go in with the idea they're going to want to take care of me. My doctor doesn't really care if I'm cash paying or if I'm coming to them through a network. They want to take the best care of me, take care of my problem, do my procedure. They want to make sure I have a good outcome. I don't think it's the physician that is the barrier. Typically, it's the system, it's the structure above them. But if we go in from the bottom up, get referred in from DPC, and I would love to hear, other people may have other experiences, but that was my experience, which gives me a lot more hope that bottom up can be a very valid way to make a difference in the system over time.
Now, here's a question from my co-host, Jim, who is an entrepreneur, creating a very interesting primary integrated space, which gets to a little pushback here on why healthy folks may resist that monthly payment. We had an osteopath, Dr. Lindley, who's the president of AEPS. My local DPC friend, Dr. Tinsley, is offering some more integrated natural therapies, and he's got that nice, comfortable office environment. My cousin was a patient of his and even had lunch with him on their back deck. So I love that, or that intimate kind of feel that you get with DPC. It's so awesome. And I love Dr. Gold to respond to what Jim's about to say, and that is how are allopath, mainly primary care DPCs, expanding their toolkit, osteopath or integrated, whatever. And Jim, go ahead.
Okay, thanks. And Dr. Gold, I love what you're doing, and Gayle, your focus on DPC. I think it is a great start. We need to be doing this from bottom up. Essentially, yeah, I think the whole system is, well, we probably all agree, the whole system needs to be rebuilt. From my entrepreneurial side, the project I'm working on is called the Pavilion, and it puts that membership model into a new space, but it's not just membership for integrative care and cost sharing and all of the programs we talk about here on Freedom Hub. But it would be kind of like going by Epcot Center, and a stunning building with the next generation of everything in it, from healthcare to foods to whatever, classes and so on. So I think that's, and the class part and the education part is a big piece, as you're talking about. We need to educate the public. So I figured if you have a big, something that's going to really grab people's attention and you put it inside of that, that's a great way to get the message out to begin with. As for what's inside, and Jeff, you made me think that maybe you guys, the primary care docs today, are more like the old family physicians of yesteryear, where you make the house calls, you talk to the people, how are you sleeping? How are you guys getting along, right? There's a lot more to that. It's not just prescribing or surgery and so on. Which brings me to, we now know that, and this education piece, we know that a lot of things affect our health, emotions, the toxins in the environment, our wireless networks, and dental. I actually, and to full disclosure, I'm also a biofeedback technician. I work with a very advanced device, and I get calls from doctors and other people to help assess their very complex patients, people with really, a mess that come into the office. So I can scan them, and it goes through 12,000 health variables. And then the doc can look and go, oh, it looks like there's some abuse there when they were young, whatever it might be, but it goes into a lot more the pathogens and so on. And I think that's it. The starting point is, first of all, we need to take care of ourselves and switch the model like the old Chinese doctors, right? You get paid to keep people healthy. And that's what I would like to see happen. I think that having that NP in your office, Dr. Gold, is a great, the way you put it, it works out because it's like a second person that can evaluate things, take the load off of you. And maybe there's even a few more that get added in our model. It could be an acupuncturist, biofeedback person that can help do that, where the doctor or the DPC doc is the manager of all these people. So your focus is on, the big issues, really. I think that's, did I answer that, Charlie? Is there something I'm
let
missing?
the guests and Dr. Gold and others respond.
Yeah,
And-
I think that,
yeah.
so go ahead, Jim, sorry.
No, I just going to go back to Buckminster Fuller. If the system is like, don't even bother trying to fix that. If we just start doing DPC and direct care and educating people through things like this and whatever, we can make a better system. Yeah.
Yeah, that's funny. I actually use that quote at the end of most of the talks I give. It's there's certain terms that kind of drive me crazy, and it's one of them is this term wellness that gets thrown around, because I look at wellness as like that's what primary care used to be. Like we talked about when you lost your dog, or if you weren't sleeping, or what was going on at work, what was going on at home. And I think that the way I always try to frame direct primary care to people is it's kind of the oldest, newest way of doing primary care. We're getting back to the humanity and art form of practicing medicine, but we're using all the technology we have to enhance it, not replace it. I mean, I'd love to hear more about what you're doing, with Pavilion, because as Gail knows, I kind of have like a separate business entity that I've created that kind of focuses on how to rebuild healthcare ecosystems across the country in the right way, because the biggest limiting factor we have right now is you got to build the demand first in order to get more of a supply. I have an angel investor that helped me out to be able to do this. As you know, most primary care doctors are highly risk averse in pretty much all aspects of life and practice, and they're not going to do what I did and some of my brethren did to really take a huge risk of financial loss, personal loss, professional risk, without a guarantee. And I can't blame them. It's a very, very scary thing when you put that key in the door and you don't know whether patients are going to sign up with you or employers are going to sign up with you. And it's very regional, where people are in other areas of the country that are more open thinking, and, things grow really quickly in areas like New York, Massachusetts, California. It's really tough to get people to think that, nothing's free. The argument that I always say against the gym membership type thing is people will say to me, well, but I go to the gym once a week. I only go to the doctor like once or twice a year. My wise ass rebuttal is, okay, then why do you pay $800 a month for insurance that you don't use? But it's hard to blame the public, because they really have been, it's the best business model in the world. They literally got people hook, line, and sinker. And we're out there trying to throw them, life rafts and buoys to say, look, we can do it better, and you can trust us. But what's happened is the trust in physicians has been disappearing gradually over time, because they don't have that relationship anymore. I mean, how many people are on Facebook in their local, town, city groups and see posts for, hey, can anyone recommend a good brain surgeon? I mean, you're literally going on a Facebook group to ask who a good neurosurgeon is, but they don't even think to call their primary care doctor, because they either don't have one, or if they do, they don't even know what that person looks like. And that's on us too. I mean, doctors share equally in the blame here. I mean, this isn't, all in the insurance companies and all in the government. It's like I say to patients who are in an abusive relationship, you only get treated the way you allow yourself to get treated. And we gave it up. The generation before us said, we don't want to manage books. We don't want to do this, do that. So let's just have the business guys come in and take care of it. Well, this is what happens, when you don't control the dollar and the flow of it, and you give it to somebody else, they're going to control you. And, I think that we're onto something here. I think it really is the only way to rebuild this system the right way. We need to really solidify the foundation and stop building the mansion on top of a foundation rotting with termites, which is what we've been doing. And, I think it takes a village. I think it takes people like George from the benefits community that get it, people that are innovative thinkers that, are not necessarily physicians, because this really is something that affects everybody. I still, to this day, I don't understand why there aren't riots in the street over this. I mean, this is literally the biggest social issue in our country right now. Whether you're black, white, yellow, purple, poor, rich, it's affecting everybody. I mean, what's going to be in Medicare when we get there? When people, George, that are our age get there? Is there going to be any money left, to take care of us? Is this what we're working our ass off for? Like, So I think that, it really does take a village. I love, chatting with like-minded people that are willing to help, because we can't do it on our own.
And with that, with time up, Gayle, why don't you say goodbye and how folks can reach you?
Yes, I did want to give a very quick shout out to the Concerned Actuaries. This ties back to what Murray was talking about a little while ago in terms of, maybe some legislative things, some, tax credits or something that we can do to promote DPC or to help it grow a little quicker. So the Concerned Actuaries are looking at, a number of different things like that. And we've got, we're doing a lot of effort right now. We're working with the Committee for a Responsible Federal Budget and some other folks to try and, promote and understand and, improve the decision-making around healthcare in this country. And their website is concernedactuaries.org. And I am available on my website, and I have a podcast. The very first podcast was with Dr. Gold, and it was about the topic that we started today with, which was how DPC docs flourish in COVID. And you can find that at descant.info. That's DESCANT.info. And you can reach me there as well. Thank you, Charles, so much for having me on today. I really enjoyed the conversation.
So what about your wealth? If your money could actually talk to you, would you listen to it? Well, with the DNA Network Academy, your money actually can talk to you, and it's going to tell you just what it told this client. This family had over 24 debts, mortgages, car loans, the works. They were on track to take 20 years to pay it all off, and instead did it in 8.5. Plus, they did it without refinancing, making more money, or even changing their lifestyle. So find out for yourself with a free analysis that is completely confidential. No personal information, no social security numbers, no credit checks, none of that nonsense. But what is exciting is that the outcome of that report you receive is a guaranteed outcome for you. To get that report, head on over to bit.ly/debt to wealth. You will arrive at this simple form. Fill it in as simple as lender number 1 and credit card number 2. What really matters is the accuracy of your numbers. You'll be able to see that if instead of 20 years or whatever your number is, that you may actually be out of debt and on your way to wealth in as little as 6.3 years like this client.